Okay, good morning, everyone. This is Neil Davis. I'm a pediatrician and have a role as medical director for community-based care for Intermountain Children's Health. And this is the beginning of a weekly series of WebEx broadcasts that we are launching from 7:30 to 8 o'clock related to the new world that we live in, defined by coronavirus. We are really grateful to have everyone that has joined on the call this morning. As a reminder, you have been muted, and because this is a large group, we do want your questions. We want them to be able to come in via the chat function. So if you use your mouse and hover near the bottom of your screen, you will see a little voice cloud. If you click on that voice cloud, then a box will come up to chat, and you can enter in a message that way. I just said, hi, everyone. So without further delay, we really want to get into the topic. But again, we do want your questions, so that is the mechanism for sending them in. We are lucky enough to have Emily Thorell here. She is a pediatric infectious disease specialist at the University of Utah Primary Children's Hospital and associate professor there. And she's the associate hospital epidemiologist. She did medical school at the University of Utah and then residency and fellowship in Kansas City at Mercy Children. So she's also just a wonderful colleague, obviously in high demand in this time. So Emily, thank you very much for being here, and we'll turn this to you. Emily's going to go through a little presentation, and then we'll have time for questions and answers. So please keep the questions coming. Go ahead, Emily.
Good morning, everybody. Thank you so much to Neil and Carolyn for inviting me to join you guys this morning. As you can understand, this has been a very fast-paced, crazy time for everyone, especially those of us in hospital epidemiology. And so I thought I'd share just a little bit about what we know, what we don't know, what you guys may have questions about, and then we'll have a lot of time for questions at the end. I don't have any disclosures. So we're going to look at the current description of the epidemiology of COVID-19 as of this morning or yesterday. We're going to look at a little bit of the Utah experience thus far, including some modeling data. Then we'll do a brief overview of the limited pediatric literature on COVID-19. We'll do a brief snapshot of the current PCH situation, and then we'll have a lot of time for questions. So as you can see, a lot of you have probably been familiar with the Johns Hopkins website. They've been really leaders since the beginning of this outbreak in tracking what's been going on worldwide. And as of this morning, you can see there are over 950,000 cases worldwide. This website is very highly interactive. You can scroll over certain areas of the country and see what's going on in every part of the world. Including the confirmed cases and the deaths. The recovered information, of course, is a little lagging. But I would encourage anyone who hasn't done this to go to this website. It's just at COVID-19@jhu.edu, or coronavirus, sorry, jhu.edu, and look at their map. And this is when you scroll down to the United States. So as of last night, there were about 215,000 cases, up to about 216,000 this morning, with about 5,000 deaths, the majority of being on the East Coast, mostly in the New York area. Utah Epidemiology, we also have a great website that I would encourage all of you to look at. So coronavirus.utah.gov. You can click on the case link and see this information that is updated daily. The case counts change a little afternoon, 1 o'clock, 2 o'clock, sometimes every day. So as of yesterday, we have 1,012 cases in the state of Utah after 20,000 people have been tested. We have 91 hospitalizations and 7 deaths, and they break it down by county. They have a nice map. You can also click in and out as well. Also on our Utah data, if you just scroll down a little bit, you can see the epidemiologic curve. I've put a couple little arrows there. The first one you can see by date. It's the number of lab confirmed cases on an epi curve. So the Utah cases are in the dark blue, and we have a few visitors, not as many as other people. But as you can see, I put arrows when we closed our schools, when we were having a bit of positive tests around the community, although that's way back when, 2 weeks ago, when we didn't have very much testing. And so we really didn't have a great picture of what was going on in our community. And then when we started having more testing and more cases, the social distancing directive as of last Friday from the governor's office. You can also see that the number of people who have been tested and the number of positives. And then you can see an age demographics table. What I'd like to point out for this presentation is that we really don't have very many children. We have one child less than 1 year old in the state of Utah, several less than 14, but just a handful. And then in that 15 to 24-year-old age group, I would say I don't see a lot of the information from the whole state, but from the Intermountain Healthcare System, most of those people are above 18. We have a handful of 15, 16, 17-year-olds, but mostly above 18. And then you can see the Utah residents, the male-female demographics, which is pretty even. As far as hospitalizations go, this graph we think is a little bit misleading because it talks about whether you're hospitalized, whether you're not, and they're on the same graph when we're actually just really wanting to look at hospitalization. So I've circled those. You can see we have no hospitalizations under the age of 15. Actually, we've had none under the age of 18 in the Intermountain system, just a handful, 15 to 24. And the majority of those are in our older demographic, so 45 to 64 and 65 to 84. And then it does keep a case count of what's going on with the percentage of hospitalizations. This is an interesting statistical modeling that you can pull up. I think I put the website, COVID-19.healthcaredata.org. This has the modeling data for the United States. You can pull down by state and look at different states and see what people are predicting as far as when the peak of the surge will occur. So this is Utah, and we think that we have April 23rd, which is now 21 days since I did this slide yesterday. It also looks at the beds needed, what our resources are, the beds needed, the ICU beds needed, and then the ventilators as far as the state data that they have. You can see that we probably are, the dotted purple line is the what we are projecting. And so we probably have enough beds. When you look at the number of ICU beds, we do fall a little bit short. So hopefully our healthcare systems are looking at this and seeing what we need. And then the number of ventilators as well, we may fall a little bit short, but hopefully this is where we're going to see that bending the curve with social distancing. The modeling, it also tells you what your state has done as far as all the healthcare interventions, such as social distancing. And so you can see what different states have done when you scroll around on this website. So what do we know about children? The first report came out a little bit before February 24th, but characteristics and important lessons about the coronavirus outbreak in China. And this was a summary report of over 70,000 cases from the Chinese CDC. Basically, it showed the age distribution that was mostly their older population as well. And really, they had 1% in the 10 to 19-year-old group and 1% in the less than 10-year-old group. Interestingly, they had a case fatality rate of 2.3%, but they had no deaths less than 9 years old. And when you read into this report, you see that they had one death in a 14-year-old, but they didn't give a lot of information about it. And then on March 12th, another paper came out from the Chinese people were still trying to deal with all of this, and it was kind of amazing that they got some literature out at all. But they reported on 366 children that were hospitalized in January for a week with respiratory infections. They found that 6.3% of them still had influenza A, that 5.5% of them still had influenza B, and that only 1.6% of them had SARS-CoV-2, or the virus that causes COVID-19. And they did a little summary of these 6 children. So we really didn't take a lot away from this. It was just kind of an interesting, oh, what did they do? They treated a lot of them with antivirals, glucocorticoids, oxygen. Some of them got IVIG. In that group of 6, they had 1 ICU admission, and that patient did seem to do a little worse and was 3 years old. Interesting, they were doing CTs on almost everybody. I think most of the literature is showing all these CT findings out of China, which did show these patchy ground glass opacities bilaterally, which is not surprising for viral infection. And then probably the best data that we have so far is characteristics of over 2,000 pediatric patients that I think is supposed to be published in Pediatrics today, but this was a pre-publication release about a week and a half ago, which seems like eternity right now. But anyway, they had about 2,100 pediatric patients with COVID-19. Interestingly, they only had 34% of those were laboratory confirmed, and 66% were suspected. The median age was 7, but they did have range from 1 day all the way to 18 years. 56% were male, which is like what we're seeing. Interestingly, 94% of this group were asymptomatic or had mild to moderate disease, and they had 1 death in that 14-year-old male. This was the same data that was reported earlier from the Chinese CDC. And when you looked at that 6% that were kind of severe or critical, they did break it down. So it wasn't very many patients, but it did seem to show that the kids that were younger seemed to have a little bit more severe or critical disease. So those less than 1, there were of 13 patients in the critical category, 7 of those were less than 1, 2 were 1 to 5, and the majority otherwise had, the mild to moderate disease. So then just the other day, we had a COVID-19 in children, or excuse me, this was a letter to the editor that accompanied that article that pointed out 3 different things. So first, while children are less likely to become severely ill than older adults, there are subpopulations with increasing risk. So they thought younger age, underlying pulmonary pathology and immunocompromising conditions have been associated with more severe outcomes with non-COVID coronaviruses in children, and so that's something to watch out for. But that did not show in the data that was presented. Secondly, the attributable risk for severe disease from COVID-19 in kids is really challenging because prior in reports of non-COVID coronaviruses have shown co-infections in up to 2/3 of cases. And with that large proportion of these patients not being test confirmed, we were concerned that maybe a lot of those could have had co-infections. And certainly that previous Chinese study showed that there was still a lot of circulating other viruses. Third, children may play a major role in community-based viral transmission. There was hints of asymptomatic carriage, prolonged shedding. And some other studies have now shown fecal carriage, so worrying about things like diapers and oral fecal spread. And then just the other day, we had a systematic review out of Sweden that looked at all of the literature. They looked at 45 different publications. They found that 2% of the cases in children were in China, 1.2% in Italy, and 5% in the US. Still showed milder disease, very few deaths. Diagnostic findings similar to what we see in adults, so fever and respiratory symptoms are common, but fewer children seem to develop severe pneumonia. They also call out that GI symptoms have been described, and we've seen several case reports in the literature of this, especially in adults that have come in for abdominal pain. They noted that in children, elevated inflammatory markers may be less common, and the lymphocytopenias that are well described in adults seemed a little more rare. Comorbidities in children were described in case reports, but really we don't have enough data to quantify those at this time. They did say in the systematic review, there are a few papers that talk about possibility of vertical transmission, and we don't really see that in this disease. They have several newborn infants that have developed symptomatic COVID-19, but it seemed to be after birth and not vertical transmission. And then a lot of treatments, including antivirals, were used in China, but not in a systematic fashion, and so it was really hard to say anything about that. So in summary, kids do overall better than adults, but their clinical characteristics are similar. Hospitalizations are few and deaths are rare, which is good news for our population. There's an unclear role of asymptomatic infection and prolonged shedding in children. We're still studying as to how long that actually is. We know this to be true for other viruses. Children less than 1 year seem to have the highest risk for severe disease based on this limited information, although most of them still do fairly well. And it is still unclear what role comorbidities in kids play. We're assuming that kids with underlying cardiopulmonary disease probably do worse, but we don't really know that yet. The role of co-infections is really unknown, and further study is needed. And then the role of therapeutics is really unknown, especially in children. Most of the ongoing clinical trials are in adults, and they're ongoing as of right now. There have been very limited data as to whether any of these interventions actually work. So locally, the good news, you can see that our other viral activity, our normal viruses are going down. So we're seeing a lot less flu, a lot less RSV, and we're thinking that, it's into early April, but it's also social distancing for the last couple of weeks has probably played a big role in this. And really interestingly, our daily PCH emergency department census has gone way down, which is really unusual. And this is not something that we would expect to see at this time of year. Some of this could be, people not bringing their kids in that don't need to come, but also a little bit worried about kids that do need to come that aren't coming. So what are we doing at Primary Children's? And, this is a huge topic that I could talk about for a very long time, but I just thought I'd pull out a couple of points and we can save some room for questions. Our current PCH census is actually really low. It's kind of interesting. We sort of feel like it's the calm before the storm. But as we also know from the experiences in our other children's hospitals, the COVID patients aren't that many. And so we do a lot of work and we worry about them, and we do find a few, and we have to worry about the transmission to our healthcare workers and other patients. But really there aren't that many kids. We don't have any COVID positive patients admitted at this time. We are, however, testing all patients who come in with fever that's not otherwise explained, and those with respiratory symptoms. So our physicians are having to nuance this a little bit, and I give kudos to them because this guidance has changed so many times, and it's really hard for them to keep up with our recommendations because they change what seems like on a daily basis. Last week when we had a little bit better testing supply, we really decided to pull the trigger and just test anybody that was admitted with respiratory symptoms. And then with this GI question, fever not otherwise explained. And then certain other populations, we have specific testing protocols like cystic fibrosis or hematology oncology. We have very limited visitor restrictions as through the whole healthcare system. So we are allowing only one parent to stay with children, and they can switch that out every day, but it has to be the same person kind of in a 24-hour period. We are now, as of yesterday, screening our staff and visitors, including a temperature screen. We've been screening them for a while and making them do hand hygiene, but yesterday temperature was added. We are facing shortages that we have to keep up with almost on a daily basis. We're doing this through the system, but also locally. So testing supplies, what do we have? There's, as you've probably heard if you listen to the news, the swabs are short, the viral reagents are short. So testing has been a moving target for sure. The personal protective equipment, yes, is definitely something that we have to look at every day. And we have to make very careful decisions because of the prevalence in our community not being super high yet, how well we can, burn through our PPE. So our stock is not too bad, but we're definitely worried that we may not get through this without a lot of conservation efforts. We're also having drug shortages, yesterday I heard there was a Precedex shortage. We know some antibiotics are short. We know a lot of the sedation meds are short. So this is making things very challenging as well, because everybody in the world is vying for all of these drugs and supplies. And a lot of these things were coming out of China, which, as you can imagine, production there had been shut down for a while. We are now masking our clinical staff as of the university put out that policy. I think it was Monday or over the weekend, and started it on Monday. And then Intermountain Healthcare is going to that today. We are discussing consolidating pediatric services throughout the system. A lot of the children's hospitals across the country are doing this, as well as it was encouraged by the Children's Hospital Association that you take all the kids out of the healthcare system that might otherwise be seen in adult hospitals, because the surge is really there. And the adult hospitals are really having a hard time. And we're starting to see that as well. We've got several adult patients in our ICUs across the system, and they're pretty sick. And so, those beds that we're going to need are adult beds. So we're trying to consolidate the pediatric patients where we can take care of them at primary children's. We're also considering seeing or admitting younger non-COVID adults as the adult hospital capacity is strained. So that might be something as we get closer and closer to our surge, we may be seeing older children, younger adults in our hospital that we normally don't see. Other children's hospitals have kind of cut their age to emergency room patients at about 30, or taking things such as trauma to the ICU that are non-COVID related, to try to cohort those COVID patients all in similar places. So outpatient strategies, I know a lot of you are doing a lot of these things, and this is just kind of a list I came up with at the top of my head, and there's probably a lot more things that people are doing and a lot more questions that we can talk about. But really, we need to be good doctors, be taking care of ourselves, and everyone needs to stay home if they're sick. This is super important, and we're not good at it. So we need to really make sure that we're paying attention to ourselves and staying home, because this virus is really tricky and we can spread it around really easily. I know a lot of you are separating your well visits and your sick visits by either time or location. I've heard both. A lot of people have turned to telehealth as a potential way to reach their patients. PPE in the outpatient setting, I know, has been hard, and some people have more supplies than others. But really, we do need to protect ourselves. And if we can do, for respiratory patients, droplet precautions with eye protection, you're really going to protect yourself as well as we are in primary children's, actually. We do know that this is there's a lot of confusing information out there right now, but as of right now, the science is really saying that this is a droplet spread organism, and that there are certain aerosol generating things, but they're kind of few and far between. We encourage increasing high-touch wipe downs and hand sanitizing stations for everybody. We encourage practicing social distancing at work. So whatever that means for your workspace, everyone needs to consider that. Consider screening your staff and have contingency plans for when your staff are ill. Consider masking staff if the supply is available. This is really to protect us from each other, because we know that there is some asymptomatic spread and reports of asymptomatic infections. The CDC has a site, and there's also local guidance from different healthcare systems on prolonged usage of these masks. So look at that if that applies to you. Protection, including N95s or PAPRs for clinically aerosol generating procedures. This includes nebulized treatments, NP swabs, and intubations, things that might happen in the clinic. And so those are things that you may need to consider alternative plans for these procedures. I know a lot of people have stopped doing NP swabs in their office, maybe send them to the testing centers for that. Nebulized medications is hard because there's also a shortage of MDIs. But anyway, there's a lot of things to discuss. And what's hard about this is that everybody kind of has, in your different area, you may have a little bit different solution to some of these problems. So with that, I'll take your questions.
So Emily, thank you very much for the information. We've had some good questions coming in. This is Neil Davis again, talking now. So a few questions about PPE, and you addressed a lot of those. One question that just came in had to do with is the change to contact droplet precautions based on evidence, or is that based on low supply of PPE?
Yeah, that's a great question, and one we get all the time. So it's not a change to contact droplet. So it's always been contact droplet with eye protection. So, and actually when you talk about droplet precautions, it always has included eye protection, but as healthcare workers, we've kind of not paid as much attention to that. So you want to protect your eyes. You want to protect yourself from those droplets. And if you think about, what they're talking about, wiping everything down when you're out, it's really to protect yourself against the droplets that may be, sitting around. Aerosol generating procedures, in theory can cause aerosolization of this virus, and which would make it more likely to hang around in the air for a little bit longer, sort of like measles. But we really aren't seeing that. And some of the studies, there's been some studies where they tried to look at that, especially one that's gotten a lot of press out of Nebraska, where they found, viral DNA in places that they thought might suggest that it might be more aerosol driven. However, we don't really know what it means when you find some viral DNA versus when you actually find virus. So we haven't studied those enough to know that, or to prove that there are aerosols in places that we don't expect them. So as of right now, and this is across the nation, and I know it's hard because a lot of people think that, oh, we don't have enough PPE, so they're probably only saying that. But no, the science really does say that it's spread by droplets, and droplets are the main thing that we need to worry about, other than some of these specific areas.
So along those lines, there was a question about suctioning, and I just have a question overall. Is suctioning, has that been a treatment that has been needed in other places around the world to care for these kids? And suctioning, is that something that requires, that's an AGP, that is suctioning an AGP, and is it an important treatment for COVID for children?
So suctioning, obviously is an important treatment in respiratory viral infections for children, but regular nasal suctioning is not an AGP. It is definitely, we have to protect ourselves against the droplets. Open suctioning of an ET tube is when you can have your aerosol generating procedures. And so when you see suctioning on those lists, it's really referring to the open suction of either a trach. So if you do have trach patients, that procedure could be concerning for aerosols, as well as open suctioning of an ET tube, but not inline suctioning.
Okay. So Emily, we had a question about a report of an infant death in Chicago related to COVID. Is that something you're aware of? Is that confirmed? And then a corollary question, are the rates of children contracting COVID higher in the United States compared to other countries? China's rate was reported to be relatively low.
So interesting question. So there have been 2 pediatric deaths reported in the United States. One was this infant in Chicago, and unfortunately we don't know any more information yet. I have not heard. Another one was a 17-year-old in the LA area. And it sounds like, unfortunately, he was turned away from medical care initially. So more to come about that, I'm sure. And then as far as, I'm sorry, Neil, what was the other part of the question?
Just are the rates of infection higher in the United States than in other places?
In children, yeah. So it's hard to know. The social distancing measures in China were pretty aggressive at first, and so maybe the kids were spared a little bit more because of that. I think after this is after we get through this for a few more weeks, we may have a little better information about that. Are we testing more? I don't know. The kids certainly don't seem to be any sicker than they were in China.
Okay. Another question that just came in, some clinics have stopped doing strep and flu swabs just to save supplies and also to be careful with potential risk to the healthcare workers. And the question is, do you think strep swabs are okay if we're using surgical masks and goggles and protection?
Yeah, so there's nothing about the strep swab that is aerosol generating. Now, what you would worry about is, we do make kids cough and gag a lot, and so they could cough droplets onto your face. So you need to be careful about that. A lot of places, if you have access to face shields, are going in that route to kind of, if you have a face shield, it'll protect your eyes and your mask so that you can wear your mask longer. So that is something to consider. And while we're talking about masks, the other thing I do want to point out, and I didn't put this in my slides, I apologize, but there's a study about cloth versus hospital grade masks that really say that cloth masks can actually increase your likelihood of getting sick. So I would be cautious about that. And I don't know if it's just because you wear them and they get saturated. So if you could, change a cloth mask every time, maybe that would be, but we don't know. So we don't really know anything about cloth masks. We think it might be a good strategy for population health, so for people at the grocery store to keep their droplets to themselves and things. But really, they're not recommended in the healthcare setting at this juncture.
Okay. Boy, we don't have much time, but we're getting so many good questions. Does COVID cause bronchiolitis?
We don't know that. I assume, as most viruses, it could, but we don't know that yet.
And then can you comment on the sensitivity of the testing for the novel coronavirus?
Yeah, so the sensitivity is actually quite high. The problem with testing for the novel coronavirus is you may test too early before you have a lot of viral replication. So it's really not indicated to test asymptomatic people because if you get symptoms 2 days later and then your test is positive, people may think that the sensitivity of the test is not that great. But honestly, it's probably because you haven't had viral replication yet. So what we're suggesting is that for testing, you, even with symptoms, unless they're pretty convincing, that you wait 48 hours, see if your symptoms are still there, and then get tested.
And then we'll take one more here. Can you comment on the potential for seasonality of the virus? And then also, what do we know about the role of herd immunity?
So both really good questions and unclear at this point. So as far as seasonality, we are concerned that, we could see a spring wave or winter spring wave and then a nice break in the summer, and it could come back in the fall, sort of like influenza. We don't really know. Other coronaviruses certainly can have seasonality, although this one being more like the MERS and SARS, we don't really know because those previous outbreaks were contained. And as far as, I'm sorry, Neil.
Oh, go ahead. Just in terms of herd immunity, that was the second piece.
The herd immunity, we are hoping, there's a few places that are using IVIG from recovered patients to treat new patients. Serologic studies are being done. In fact, the CDC is using Utah for one family serologic study. So we'll have some more information about that, but right now we really just don't know.
Okay, I'm going to just do one more because this was a good question that just came in. How aggressively should we be testing kids with mild symptoms? How aggressively do we recommend that families go through and get the drive-through testing for kids?
Yeah, that's a great question. Certainly what the governor says is that he wants everybody to be tested. He kind of wants to know what's going on in the community. However, it's really hard because we don't have the supplies. We want to be careful about how to test. And so what we've been recommending is that, if you want to test one person in the family, I think that's probably reasonable. I think it's probably good for people to know, yeah, this is COVID, then they know, then, if we have information down the road about if that's protective, then that might be good for them to know. It also probably makes them take social distancing a little more seriously. So those are the things that we're suggesting. We do have to be careful about our supplies, so I wouldn't send, a family of 8 to all go be tested.
Okay, very good. Emily, thank you so much for your time and your expertise. So much appreciated. To all of you on the phone, we are tracking the questions that you're sending in. We do want to know what would be useful for you to hear about next week. Another update epidemiologically, what type of information would be useful. I did want to show everyone before we're done that we have a website now. We received feedback that it would be nice to sort of have a central place, at least with Intermountain Children's Health primaries, where we're listing information related to children. So this was just launched yesterday evening, and you can see the URL at the top of your screen right now. And if you search this site, it gives an overview on information related to COVID and children. There's some clinical guidance here as well from American Academy of Pediatrics, which in my opinion has had incredible information for practices. I do want to mention the Utah chapter of the AAP. They have a podcast many of you are probably familiar with called Virtual Curbside, vcurb.org. And it is outstanding. And just on Tuesday, they released a podcast with Andy Pavia, another infectious disease expert. It's outstanding. It's about 45 minutes long. Q&A with Paul Werkus, the president of the Utah chapter of the AAP. Really, really good information. I'd strongly recommend that. So there's other information here as well. We are going to be posting the recordings of these WebExes where you can link to that on this website. Please contact me, email me with items for discussion, questions. We'll be curating that information to try and actually find out what is useful for you clinically as providers for children related to this COVID pandemic. So a couple of the things to look at, there are new policies related to newborns and how we're managing newborns in the hospitals related to COVID. Strongly encourage you to take a look at that as well. So other things on this website, we can't cover everything, but I did want to highlight this as this is some feedback that we received from you. So thank you everyone for attending the WebEx. Emily, thank you again. Your expertise is invaluable now and we really appreciate your time.
Well,
so to everyone, yeah, thanks for joining and have a great day.